Before we dive in, let's take a mindful pause. Close your eyes if you're able. Let's take a deep breath in and exhale fully. Again, inhale slowly through your nose. Hold and release. One more. Inhale, hold, exhale. As you breathe, bring to mind something or someone you're grateful for today. Maybe a moment of kindness, a mentor, perhaps your own persistence. This grounding can really help you focus better, retain more, and hopefully reduce stress while learning. And that's what this space is all about. And before we jump in, a huge thank you to those who've already subscribed. You're helping this channel grow and reach more students who really need this kind of focused review. If you're new here, welcome, and feel free to subscribe if you find this deep dive helpful. Welcome to the deep dive. Today, we're plunging into a topic that's absolutely critical for anyone in healthcare: sexually transmitted infections, or STIs. This isn't just about individual patient care. It's a massive public health challenge. Get this, approximately 1 in 5 persons in the United States, totaling about 68 million individuals, currently has an STI.
Well, it's a staggering number, and it truly underscores why understanding these infections is so vital.
It really is a vital area because these infections are far more than just, a nuisance. They're profoundly linked to symptomatic disease. They can lead to infertility, and they have deeply detrimental effects on pregnancy and childbirth. So this makes a comprehensive grasp of their diagnosis, treatment, and especially the counseling pearls incredibly important for all healthcare professionals.
Exactly. So our mission today is to equip you with that comprehensive understanding. By the end of this deep dive, you will be able to identify the most common sexually transmitted infections and their causative organisms. Recall first-line CDC treatment guidelines. Recognize when a test of cure or partner treatment is required. Counsel patients on adherence, partner notification, and reinfection prevention, and apply best practices for treatment during pregnancy and in co-infected individuals. Okay, so let's lay the groundwork by talking about prevention first, because if left untreated, STIs can lead to some really serious long-term complications.
Absolutely. The primary goals of prevention are, they're crystal clear. We want to avoid disease transmission between partners, prevent vertical transmission from mother to child, that's what we call intrapartum transmission, and of course prevent those severe long-term complications. When we talk about the most reliable prevention methods, they really remain abstinence and consistent barrier contraception, primarily condom use. It's also worth noting that human papillomavirus, or HPV, is currently the only STI for which a vaccine is available for prevention, and once someone is infected, counseling becomes paramount. Patients and all their sexual partners from the previous 60 days should seek treatment. And both parties must abstain from sexual practices for up to 2 weeks post-treatment to prevent transmission and reinfection. And it's important to remember methods like vaginal diaphragms, hormonal contraception, hysterectomy, or surgical sterilization. They offer no protection against STIs.
That's a great overview of the practical side. Now, to truly get at the heart of patient care and counseling, there's a really helpful framework known as the 5P questions. These are pretty essential for a thorough patient assessment done sensitively. The 5 Ps are: first, partners. Do you have sex with males, females, non-binary individuals, or maybe more than one of the above? How many partners have you had in the past 2 months? Second, practices. To understand your risks of STIs, I need to understand the kinds of sex you have had recently. Third, prevention of pregnancy. What are you doing to prevent undesired pregnancy? Fourth, protection of STIs. What do you do to protect yourself from STIs and HIV? And finally, previous history. Have you ever had an STI? Have any of your partners?
Yeah, that framework provides a kind of roadmap for gathering crucial information. And speaking of assessment, it's critical to highlight that STI testing is routinely recommended for all sexually active persons under the age of 25, or for individuals with inconsistent condom use, a previous or coexisting STI, or those exchanging sexual acts for money or drugs. Early identification is always key.
Okay, now that we've got that foundational understanding of prevention and counseling, let's zero in on some of the most frequently encountered bacterial STIs. We'll cover chlamydia, gonorrhea, bacterial vaginosis, and an emerging challenge, Mycoplasma genitalium. The general principle here is that treatment is indicated at diagnosis or symptom presentation. The goals are always cure, symptom elimination, complication prevention, and transmission reduction. And as a best practice, patients with STIs should also be screened for HIV co-infection.
Absolutely. Let's kick off with chlamydia. This is C. trichomonas, an obligate intracellular pathogen. What that means is it can only survive and multiply inside our cells, which makes it particularly good at hiding from the immune system and sometimes a challenge for certain antibiotics to reach effectively. It's the most common bacterial STI, transmitted via vaginal, anal, or oral sex. In women, it often causes cervicitis, and in men, urethritis. A major challenge is its high rate of asymptomatic infection. Get this, up to 70% of women and 50% of men may not even know they have it. When symptoms do appear, women might experience things like mucopurulent vaginal discharge or postcoital bleeding. Men often present with dysuria, painful urination, and urethral discharge. Untreated, it can lead to severe complications like pelvic inflammatory disease or PID, ectopic pregnancy, premature delivery, and infertility. Diagnosis primarily uses nucleic acid amplification tests, known as NAT. They're recommended because of their high sensitivity and specificity.
Okay, so with chlamydia being so widespread and often silent, what's the first-line treatment today? Especially considering those shifts in guidelines we've seen recently.
That's a critical point because the guidelines have indeed shifted. The first-line treatment for chlamydia is now doxycycline. That's DOXYCYCLINE, 100 milligrams taken twice daily for 7 days. This is a significant change from previous recommendations that often included a one-time dose of azithromycin. However, due to increasing azithromycin resistance and, frankly, a higher rate of treatment failure for rectal and oropharyngeal infections, doxycycline is now strongly preferred. How doxycycline works is it reversibly binds to the 30S bacterial ribosomal subunit, which then inhibits bacterial protein synthesis. Now for alternatives, azithromycin, azithromycin, 1 gram taken as a single dose can still be used, especially safe for pregnant patients, those who might struggle with adherence to a 7-day course, or individuals with a tetracycline allergy. Levofloxacin, LEVOFLOXACIN, 500 milligrams once daily for 7 days is another option.
Okay, quick recall question for you listening. What is the first-line treatment for chlamydia in non-pregnant adults?
That would be doxycycline, 100 milligrams twice daily for 7 days. And here's an important counseling point. Because Neisseria gonorrhea co-infection is so common with chlamydia, presumptive therapy for chlamydia is recommended when you're treating gonorrhea.
That makes sense. Speaking of gonorrhea, tell us about that one. What are we dealing with there?
Right, gonorrhea. It's caused by N. gonorrhoeae, which is a gram-negative diplococcus. It's transmissible through sexual contact with the genitals, mouth, or anus. Like chlamydia, it can be asymptomatic, but it often causes cervicitis in women and urethritis in men. Symptoms in men typically include that painful urination, dysuria, and a purulent urethral discharge. In women, symptoms might include vaginal discharge, dysuria, and maybe some vaginal bleeding. The complications are serious: PID, ectopic pregnancy, infertility, and it also significantly increases susceptibility to and transmission of HIV. A major ongoing concern with gonorrhea is the problem of antimicrobial resistance. This means treatment guidelines are constantly evolving. Diagnosis is primarily via NAT, and empiric treatment should be administered immediately for symptomatic patients because of the significant public health implications.
Yeah, with those resistance concerns being so dynamic, what is the current recommended treatment for gonorrhea? I know this has been a bit of a moving target.
It certainly has. The CDC now recommends higher doses of ceftriaxone, that's CEFTRIAXONE, as monotherapy. This is a direct response to increased minimum inhibitory concentration, basically. It takes a higher dose of the antibiotic to stop the bacteria now. Plus, there are variations in drug kinetics in patients with obesity and, of course, that increasing azithromycin resistance. For dosing, if the patient is less than 150 kilograms, it's ceftriaxone 500 milligrams intramuscularly or IM as a single dose. If they're 150 kilograms or more, it's ceftriaxone 1,000 milligrams IM as a single dose. Ceftriaxone, it's a third-generation cephalosporin. It works by binding to and inactivating penicillin-binding proteins, which ultimately leads to bacterial cell death. Alternatives: well, IV ceftriaxone 1 to 2 grams is a single dose if the IM route isn't available. Oral cefixime, CEFIXIME, 800 milligrams as a single dose is another option. Now, for patients with a documented severe penicillin outage, the recommendation is gentamicin, GENTAMICIN, 240 milligrams IM as a single dose, PLUS azithromycin 2 grams orally as a single dose. And importantly, for any of these alternative regimens, a repeat test of cure is recommended to confirm eradication.
Okay, let's shift slightly. What about bacterial vaginosis, or BV? It's not always considered a classic STI, but it comes up a lot in this context.
Right. BV isn't strictly an STI in the same way, but it's an extremely common condition. It's characterized by a shift in the vaginal microbiota. Essentially, the protective lactobacillus species decrease, and a more diverse, often problematic mix of bacterial species takes over. Symptoms can include vaginal discharge and a distinctive odor, though a large percentage, maybe 50% to 70%, are often asymptomatic. Complications include an increased risk of HIV transmission and also acquiring other STIs. Diagnosis is also primarily by NEAT. For treatment, the preferred regimen is oral metronidazole, METRONIDAZOLE, 500 milligrams taken twice daily for 7 days. Alternatively, metronidazole gel 0.75% applied intravaginally once daily for 5 days, or clindamycin, CLINDAMYCIN, cream 2% applied once daily at bedtime for 7 days, can be used. It's important to note that a 7-day oral course of metronidazole is generally more effective than a one-time dose. And here's a surprising fact. Recent evidence actually challenges the long-held belief that metronidazole interacts with alcohol to cause a disulfiram-like reaction.
Right.
Yeah. So that common instruction to avoid alcohol might not be as critical as we once thought.
That is interesting about metronidazole and alcohol. Now, let's talk about an emerging STI that's becoming a genuinely unsettling challenge. Mycoplasma genitalium, or MGen. What makes this one so tricky?
Gen is particularly concerning because it lacks a cell wall, which makes it inherently resistant to an entire class of antibiotics, the beta-lactams, like penicillin. Its symptoms are often indistinguishable from chlamydia, actually causing up to maybe 30% of non-gonococcal urethritis and cervicitis cases. Complications include PID, preterm labor, and infertility. Diagnosis relies primarily on NAT, and because of these growing concerns about resistance, routine macrolide resistance testing is now advised. This is crucial because macrolide resistance rates are alarmingly high, exceeding 60% in some populations.
Wow, over 60%. So how do you treat it then, especially with that resistance?
It's complicated. For treatment, if it's a macrolide-sensitive strain, the recommended approach is doxycycline 100 milligrams orally twice daily for 7 days, followed by azithromycin 1 gram orally as a single dose on day 8, then 500 milligrams orally daily for 3 more days, days 9 through 11. But for macrolide-resistant cases, the regimen shifts. It's doxycycline 100 milligrams orally twice daily for 7 days, followed by moxifloxacin, MOXIFLOXACIN, 400 milligrams orally daily for 7 days. Moxifloxacin should really be reserved for documented resistance or when sensitivity testing isn't available. You know, when macrolide resistance rates soar past 60%, it's not just a statistic. It's a stark warning that MGen might become one of our first truly incurable bacterial STIs in decades. It really emphasizes the urgent need for ongoing research and new treatment approaches.
That's a sobering thought of the potential for incurable bacterial infections. Let's move on to more complex territories, the severe STI-related conditions, starting with pelvic inflammatory disease, or PID.
Right, pelvic inflammatory disease, PID. It's a serious complication that arises from untreated, undertreated, or resistant chlamydia and/or gonorrhea infections. It can lead to the formation of scar tissue in the uterus, fallopian tubes, and/or ovaries. This scarring significantly increases the risk for ectopic pregnancy. It disrupts the delicate cilia lining the fallopian tubes, which are supposed to move fertilized eggs towards the uterus. PID can be caused by various organisms, including N. gonorrhea, C. trichomoniasis, and Mycoplasma genitalium, among others. Diagnosis is typically done with NAID, similar to other STIs.
And the treatment must be more aggressive.
Definitely. Given its severity, treatment for PID is more aggressive than for uncomplicated STIs. The outpatient regimen typically involves ceftriaxone 500 milligrams IM as a single dose, plus doxycycline 100 milligrams orally twice daily for 14 days, plus metronidazole 500 milligrams orally twice daily for 14 days. So you see, higher doses of ceftriaxone are recommended, and a single course is definitely not sufficient given the risk for long-term complications. If a patient has a severe penicillin allergy, Astrium can substitute for ceftriaxone, and azithromycin can substitute for doxycycline if it's contraindicated or not tolerated.
Okay, here's another recall question for you. What STI often requires both IM ceftriaxone and oral doxycycline due to co-infection risk, and also needs extended treatment for complications?
That would point towards pelvic inflammatory disease, or PID.
Good one. Next up, let's talk about syphilis, caused by Treponema pallidum, that spiral-shaped bacterium, transmissible through various sexual contacts. It's really fascinating and kind of scary how this infection can mimic so many other conditions and progresses through such distinct stages if left untreated.
It's truly a master of disguise. Untreated syphilitic disease progresses through 4 key stages. First, primary syphilis, characterized by that painless ulcerative chancre at the site of entry, typically around 3 weeks post-transmission. It might be easy to miss. Then, secondary syphilis. Here, you often see a diffuse rash, classically affecting the palms and soles, maybe 8 weeks after transmission. Often comes with other systemic symptoms like fever or swollen lymph nodes. Next is latent syphilis. This is where there's a positive serologic diagnosis, but no clinical symptoms are present. It can be early or late, and it's critical because it remains potentially transmissible. Finally, tertiary syphilis. This encompasses the long-term complications, things like granulomatous disease, cardiovascular syphilis. This stage is generally not transmissible but can be severely debilitating. And importantly, neurosyphilis can occur at any stage of the disease, primarily affecting the meninges and cerebrospinal fluid. It demands immediate attention.
And diagnosis isn't straightforward either, right? Since you can't just culture it.
Exactly. Since T. pallidum can't be easily cultured, we rely heavily on serologic testing. Non-troponemal tests like VDRL and RPR are used for initial screening. Positive results are then confirmed by troponemal-specific tests. For neurosyphilis, it's usually a combination of clinical signs, serology, and CSF evaluation, with the VDRL-CSF being the standard serologic test for cerebrospinal fluid.
And treatment. I know penicillin is key here.
Absolutely. Parenteral penicillin, spelled Penicillin, is definitively the drug of choice for syphilis, no question. There are specific preparations and regimens based on the stage. For primary, secondary, and early latent syphilis, it's benzathine penicillin G 2.4 million units IM as a single dose. For late latent penicillin G 18 to 24 million units IM weekly for 3 doses. And for neurosyphilis, it's aqueous crystalline penicillin G 18 to 24 million units daily given intravenously or IV, either every 4 hours or as a continuous infusion for 10 to 14 days.
Okay, and there's something important patients need to know about when they start treatment, right? That reaction.
Yes, a critical counseling point. The Jerisch-Herxheimer reaction. This is an acute febrile reaction, fever, chills, muscle aches that can happen within hours of starting treatment, especially common in early syphilis. It's caused by the sudden release of cytokines from the T. pallidum organisms as they're killed off. Patients should be counseled to expect symptoms like myalgia, headache, tachycardia. They usually subside within 24 hours and can be treated with over-the-counter analgesics like acetaminophen or ibuprofen. It's also crucial for us healthcare professionals to use the correct penicillin preparations. There's a specific warning about accidentally giving Bacillin CR instead of Bacillin LA. For syphilis, CR has only half the needed dose. For a true penicillin allergy and less severe disease, doxycycline might be considered. But for more severe disease like neurosyphilis or in pregnancy, penicillin desensitization is required because there are no fully proven alternatives. And a vital safety note, neither procaine nor benzathine penicillin should ever be given intravenously. Serious risks involved.
Okay, very important points. Let's shift gears to some other significant STIs, starting with trichomoniasis. This one's actually the most common curable STI, caused by that protozoan, Trichomonas vaginalis.
That's right. Trichomoniasis can present with symptoms like purulent vaginal discharge in females, or maybe a mucopurulent urethral discharge in men. But again, many patients are asymptomatic, making them unaware they can transmit it. Complications can include PID and an increased risk of HIV transmission. Diagnosis, again, most reliably done using NITE. For treatment, we primarily use the nitramidazole drug class that includes metronidazole, tinidazole, tinidazole, and sectidazole, secnidazole. The preferred regimen for females is metronidazole 500 milligrams orally, twice daily for 7 days. For males, it's typically metronidazole 2 grams orally as a single dose. It's important to emphasize, though, that for women, that 7-day course of metronidazole is more effective in treating trichomoniasis and reducing treatment failure or recurrence compared to the single-dose strategy.
Okay, and moving into viral infections, let's talk about genital herpes. This is a chronic, lifelong thing caused by herpes simplex virus, HSV1 or HSV2.
Correct. It manifests as those characteristic clusters of painful papular and vesicular lesions, usually on the external genitalia. Recurrences are common, unfortunately, but they do tend to become milder over time for most people. Diagnosis is usually done through virologic tests, like PCR from a lesion, or sometimes serologic tests for antibodies.
So with genital herpes, the antivirals don't cure it, but they're absolutely essential for managing the disease, right? Helping control symptoms and transmission.
Exactly. Antiviral agents like acyclovir, ACYCLOVIR, valacyclovir, VALACOBVIR, and famciclovir, FAMCLVIR, are used in 3 main ways. There's treatment for the initial episode, which is often the worst. For example, acyclovir 400 milligrams orally 3 times daily for 7 to 10 days, or valacyclovir 1,000 milligrams orally twice daily for 7 to 10 days. Then there's intermittent therapy or episodic therapy for recurrences, like valacyclovir 500 milligrams orally twice daily for just 3 days, started at the first sign of an outbreak. And finally, there's daily suppressive therapy. For instance, valacyclovir 500 to 1,000 milligrams orally once daily. This daily therapy is key for reducing the frequency and severity of recurrences, and really importantly, it significantly decreases viral shedding, which helps reduce the risk of transmission to partners.
Got it. And finally, a really big one, human papillomavirus or HPV. This is ubiquitous and clinically significant, especially known for its strong association with genital warts and various cancers, cervical, anogenital, even oropharyngeal cancers.
Yes. And while most HPV infections are actually asymptomatic and self-resolving, its undeniable link to cancer makes it a major public health concern. Diagnosis, when needed, typically involves molecular testing via polymerase chain reaction, or PCR, to detect HPV DNA or RNA, often as part of cervical cancer screening. Treatment primarily focuses on managing the associated disease, like removing genital warts through methods like cryotherapy, laser therapy, or topical treatments like imiquimod or Podophylox. There isn't a specific antiviral medication for HPV itself, but the most impactful approach by far is immunization. The 9-valent HPV vaccine, Gardasil 9, is routinely recommended at age 11 to 12 years, though it can be started as young as 9. For adults aged 18 up to 45 years, vaccination is considered through shared clinical decision-making. It offers a vital layer of protection against the most common cancer-causing and wart-causing types.
Okay, pausing here for a second. If you're finding this helpful so far, I'd be so grateful if you'd hit like, subscribe, or maybe even share this with a classmate. Your support really helps keep this project going. Now let's try to put some of this into a practical scenario. Let's say you're counseling a patient. They've just been diagnosed with both gonorrhea and chlamydia. How would you explain the treatment and, crucially, the importance of treating their partner?
Okay, yeah, this is a really common scenario. It's exactly why we talked about presumptive therapy for chlamydia when treating gonorrhea. So for this patient, I'd explain that they likely have both infections, and because it's so common to have them together, we treat for both simultaneously just to be safe. I tell them the primary treatment would be that single shot, the intramuscular ceftriaxone for the gonorrhea, and then the 7-day course of oral doxycycline pills for the chlamydia. Then I'd really need to explain the absolute necessity of their sexual partner or partners from the past 60 days also seeking evaluation and treatment. We'd emphasize abstaining from all sexual activity until both they and their partners have completed the full course of treatment and any symptoms have totally resolved, typically. That means waiting at least a full week after finishing the antibiotics, maybe even 2 weeks, just to be absolutely certain. This is crucial not only to prevent the patient from getting reinfected, but also to break the chain of transmission in the community and prevent serious complications for their partner or partners.
That makes perfect sense, hitting all those key points. Now let's wrap up by covering some special considerations, starting with STIs in pregnancy. This is obviously a very sensitive and important area with some unique nuances.
It truly is. For pregnant patients, prompt identification, testing, and appropriate treatment of STIs are just vital. It helps decrease pregnancy complications and prevent that vertical transmission mother to child, either during childbirth or sometimes even in utero. For screening, chlamydia, gonorrhea, and syphilis are routinely screened at the very first prenatal visit, and sometimes they're rescreened in the 3rd trimester based on risk factors like age or new partners. It's important to note, though, that routine screening is not currently supported for asymptomatic bacterial vaginosis, trichomoniasis, or genital herpes in pregnancy. Also, there aren't specific screening recommendations for HPV during pregnancy itself.
And treatments might change a bit too.
Yes, treatment nuances are key. For chlamydia in pregnancy, azithromycin is generally preferred over doxycycline due to safety profiles. And for syphilis, benzathine penicillin G is absolutely the cornerstone therapy. If a pregnant patient has a penicillin allergy, desensitization is required because there are just no other proven alternatives during pregnancy that ensure the baby is also treated. Generally, tetracyclines like doxycycline and fluoroquinolones like levofloxacin or moxifloxacin are avoided during pregnancy due to potential risks to the fetus.
Okay. What about the interplay of HIV co-infection when we're dealing with STIs? How does that change the landscape?
HIV co-infection definitely impacts STI management. Syphilis, in particular, has a profound effect. Those ulcerative lesions from syphilis can significantly enhance HIV transmission risk by creating direct pathways for viral entry. For genital herpes, HIV co-infection often leads to more severe or prolonged episodes. This might mean needing higher doses or longer treatment durations for herpes recurrences. Crucially, though, for chlamydia, gonorrhea, and trichomoniasis, the actual treatment regimens generally remain consistent regardless of HIV status. However, it is imperative to consult current treatment guidelines for specific recommendations, especially for immunocompromised patients, as their immune status can influence the clinical course and how they respond to therapy.
Right. Always check the latest guidelines.
Yeah.
But let's touch on some proactive strategies like expedited partner therapy or EPT and post-exposure prophylaxis, PPP. How do these fit into preventing STI transmission?
These are really pivotal public health strategies. Expedited partner therapy, EPT, involves providing STI medications or prescriptions directly to the diagnosed individual for them to give to their sexual partners. The partners get treated without needing their own prior medical evaluation. This dramatically speeds up treatment for partners and helps reduce ongoing transmission in the community. However, there's an important caveat. EPT is not indicated for all partners. For example, it's generally not recommended for men who have sex with men, MSM, or partners of individuals with syphilis or HIV, or partners who are pregnant or might be pregnant. These situations require more specialized care, additional testing, and specific follow-up.
And PP, post-exposure prophylaxis.
Right. STI post-exposure prophylaxis, or PP. A key example is doxycycline PP, often called doxypep. This involves taking a single dose of doxycycline, usually 200 milligrams, within 24 to 72 hours after having unprotected sex. Studies have shown this significantly decreases rates of chlamydia and syphilis, particularly in populations of men who have sex with men and transgender women. Research is ongoing to see how effective it is in cisgender women. Additionally, as a specific point of intervention, sexual assault survivors typically receive one-time prophylactic doses of ceftriaxone and azithromycin for gonorrhea and chlamydia PP, and females also receive metronidazole for trichomoniasis prevention. These targeted interventions are vital in preventing infections after potential exposure.
Wow, okay. STIs are clearly such a vital part of patient care, and pharmacists have a huge role in diagnosis support, counseling, and overall public health. If today's deep dive brought some clarity to this complex topic for you, please subscribe, like, or maybe share it with someone else studying for their boards or getting ready for rotations. Thanks again for being part of this community. Until next time, keep learning, stay grounded, and take good care. And before we go, here's something to think about. Considering those alarming concerns about antimicrobial resistance in STIs like Mycoplasma genitalium and gonorrhea, how might future prevention and treatment strategies need to evolve? How do we ensure we don't face the reality of truly incurable bacterial infections down the road? Definitely something to keep in mind as you continue your own learning journey.